Yeah.
Thank you. The next presentation will be made by Dr. Döhner, University of Ulm, Germany.
Dear Maria Teresa, Professor Leone, dear colleagues, first of all, I would like to thank the organizers for inviting me to this network meeting here in Rome about the highlights in therapy-related myeloid leukemias. It's really a great honor and pleasure for me to be here today. So what I would like to do within the next 25 minutes is to discuss with you the International Consensus Classification, the ICC, and the update of the 2022 European Leukemia Net recommendations of AML. So here are my disclosures. So the ICC and the ELN were two initiatives that were developed in parallel in a very close collaboration. And many ELN panel members have also been clinical advisors for the ICC. And just to remind you to the 2016 revision to the 4th edition of the WHO classification that is shown here with the 4 major categories that have been included, that was AML with myelodysplasia-related changes, the AML-MRC defined by previous history of MDS or MDS-MPN, then by MDS-related cytogenetic abnormalities, and by multi-lineage dysplasia. And then the 2 other categories, therapy-related AML, as well as AML not otherwise specified. So considerable changes have now been made in the new ICC, and I summarize the major ones on this slide. So first, there are changes with regard to the blast threshold defining AML. An AML with recurrent genetic abnormality now requires a 10% plus, which was introduced mainly to consistency across the different entities. And then for the other categories, there is an important change in the nomenclature. Cases with 10 to 19% blasts are now designated MDS-AML, and that means, as a consequence, MDS-EB2 is now eliminated in the ICC, and cases with more than 20% of blasts are now called AML. So there was a broad consensus that the term MDS-AML much better reflects the genetic and clinical continuum of the disease. And this does not automatically imply that all patients with MDS-AML now be treated as an AML, but this terminology will also allow patients to be entered on either an MDS or an AML clinical trial, and also allowing access for these patients to novel therapeutic agents. So importantly, 3 novel genetically defined entities have been introduced by the ICC: AML with mutated TP53, AML with myelodysplasia-related gene mutations, and I will come back to this in a minute, and then AML with myelodysplasia-related cytogenetic abnormalities. And for the antecedent AML history, the classification now describes prior MDS or MDS-MPN or prior therapy as qualifiers, and qualifiers to the diagnosis rather than as a separate category. And as a consequence of all these changes, the category AML-MRC was eliminated. So first of all, I would like to discuss with you some issues on the blast thresholds. And this is, as you know, 20% of blasts so far have been used to distinguish AML from MDS. And this is data from a Perspective article that was published last year about the blast threshold. And what has been performed in this study, this is a study by Eli Estey, and he had analyzed Seattle data from almost 1,000 patients with MDS, EB2, and AML, according to the definition of the WHO. And as you can see on the left side of this slide, in univariate analysis, overall survival of MDS EB2 patients, as shown here by the red curve, was somewhat inferior compared to patients with AML. And after accounting for age, the performance status, and importantly also for the genetic risk, patients with MDS, EB2, and AML had similar rates of survival and response to treatment. And this is for sure challenging the arbitrary blast threshold of 20% for the diagnosis of AML. And many cooperative groups have already included the MDS EB2 category in their clinical AML trials. So as I mentioned before, the former category AML with myelodysplasia-related changes, the AML-MRC, was eliminated or is eliminated in the new ICC because there were quite a few issues with this category. And first, clinically, secondary AML has not been uniformly defined. That means, for example, different latency periods have been used, for example, more than 3 months versus more than 6 months versus now time period. And importantly, the diagnosis of preceding MDS was often not confirmed by standard diagnostic workup and was only based on changes in the blood counts. But most importantly, the clinical definition of secondary AML lacks a biological basis. And finally, one of the defining criteria for AML-MRC, the multilineage dysplasia, has no independent prognostic significance. And in addition, there is only a moderate reproducibility. So one of the first studies, if not the first study at all, that identified a gene signature for secondary AML was the study performed by Coleman, Lindsley, and colleagues. And what they did, they compared the mutational profile of 93 clinically defined secondary AML cases with 180 de novo AML cases from the Cancer Genome Atlas. And they identified a gene mutation signature that was characterized by the 8 genes that are shown here on the left-hand bottom in red. I hope I will show them later again. These 8 genes had a greater than 95% specificity for the diagnosis of secondary AML. And in the next step, they validated the clinical impact of this gene signature in 105 unselected elderly clinically defined de novo AML cases. And here they found that 33% of these patients had this secondary AML type mutation signature. And these patients, interestingly, also shared clinical pathologic characteristics with clinically confirmed secondary AML patients. And these patients, as you can see here by this Kaplan-Meier plot, these patients had a poor prognosis, as indicated here by the dark blue curve. So this is data from our own study, a targeted sequencing study that we have performed several years ago together with Eli Papa-Emmanuel. And we had used a different approach. So it was not the goal of our study to identify a gene signature for secondary AML. Our aim was to identify genomic classes of AML. And interestingly, one of the classes that we have identified was the so-called chromatin spliceosome class. And classification in the chromatin spliceosome class required 1 or more mutations in the 10 genes that are marked here in red. And interestingly, this list of genes is almost identical to the signature that has been identified by Coleman Lindsley. And this class was associated with older age, lower white blood cell counts, incident myeloid disorder, multilineage dysplasia, and inferior outcomes, so all features of AML with myelodysplasia-related changes. And in addition, there is another unpublished study from the Horn group on more than 2,000 AML patients, and they identified, again, an almost identical gene signature. So overall, there is a remarkable consistency across the different studies with regard to this gene signature. So, and this slide highlights the prognostic impact of this secondary AML myelodysplasia-related gene mutation signature, so as it is now reflected in the ICC and the ELN risk categorization. So on the left, you can see the data from our own study, the overall survival for the chromatin spliceosome group that is defined by this myelodysplasia-related gene mutation signature. And you can see that the overall survival for these patients is very poor, indicated by the red curve. And on the right, you can see data from a study from Taiwan that was presented at the last EHA meeting, also showing a poor outcome of this patient group. With the next slides, I would like to briefly discuss with you AML with mutant TP53. So for AML with mutated TP53, there is now accumulating more and more evidence, both from a molecular as well as from a clinical perspective, that AML and high-risk MDS, MDS-EB, with mutated TP53 represent a distinct molecular disease entity. And this is data that has been published by the Hoven group last year. And from a genetic perspective, there are two major interesting characteristics. So first, there is a high association of TP53 mutation and complex karyotype. 84% of the patients with TP53 mutations had a complex karyotype. And second, what was really striking, there is a paucity of concurrent mutations, as shown here on the right part of the slide. And half of these patients do not have a co-mutation. And in the remaining patients, most of the concurrent mutations were known contributors of age-related clonal hematopoiesis, such as DNMT3A, TET2, and ASXL1, that lack prognostic significance. And clinically, mutations in TP53 are associated with a very poor outcome. And you can see here the Kaplan-Meier plot on the left. The outcome is very poor, irrespective of whether the disease is categorized as AML or as high-risk MDS, as shown here by the red curve and by the dark blue curve. And on the right, you can also see that the outcome is also very poor, irrespective of whether there was a single or multiple mutations in TP53. And this is different from lower risk MDS. And the same was found for comparing mono versus biallelic TP53 mutations, and also for different variant allele frequency thresholds. And concurrent mutations only conferred a limited survival benefit in these patients. So from a clinical and molecular perspective, these data provide strong evidence that mutant TP53 AML high-risk MDS should be considered as a distinct disease entity in the AML classification. So this slide gives you an overview on the new classification. So within the group of AML with recurrent genetic abnormalities, only few changes have been made. I've already mentioned that there was a change in the blast threshold with 10% for all these different AML types that belong to this group. And there was one redefinition for patients with a CPB alpha mutation, and I will come back to this in a moment. And then the new genetically defined categories, AML with mutant TP53, AML with myelodysplasia-related gene mutations defined by one or more mutations in these 9 genes listed here, and then AML with myelodysplasia-related cytogenetic abnormalities, and AML not otherwise specified. And these 4 categories are designated MDS-AML if the blast count is 10 to 19%, and AML in case of 20% of blasts or more. So I think it is really important to note that the ICC is a hierarchical classification. And on the top of this hierarchy is AML with recurrent genetic abnormalities. It trumps all other categories. So if there is no genetic if there's no recurrent genetic abnormality, but there is a TP53 mutation, then the disease is designated MDS-AML with mutated TP53 in case of 10 to 19% blasts, or it is designated AML with mutated TP53 in case of 20% blasts or more. If there is none of these 2, but there are 1 or more mutations in these 9 genes, then the disease is designated MDS-AML or AML with myelodysplasia-related gene mutations. And if there is none of these 3, but there are some other chromosomal abnormalities, then this case is designated MDS-AML or AML with cytogenetic, with myelodysplasia-related cytogenetic abnormalities. And this is a rather small group. For example, the complex karyotype, since the complex karyotype is associated, or 5q minus or 7q minus or -7 and 5, -5, these aberrations are highly associated with TP53 mutations. So this is a really small group. And the remaining cases are AML not otherwise specified. And to all of these categories, there are these 3 diagnostic qualifiers: therapy-related, prior MDS, MPN, or germline predisposition that are appended to the above diagnosis. So what is the major difference to the updated WHO classification? And I tried to summarize the most important points. So with regard to the AML defining recurrent genetic abnormality category, the WHO also eliminates the blast cutoff in most of these AML types belonging to this category. And with one exception, this is not the case for patients with CPB alpha mutation. So here 20% blasts are required to diagnose AML. And another important difference is that the WHO retains the 20% blast cutoff to delineate MDS from AML. With regard to mutated TP53, the WHO does not categorize TP53 as a genetically defined entity. With regard to the myelodysplasia-related gene mutations, RUNX1 mutations have not been included in the list of genes by the WHO. And with regard to the myelodysplasia cytogenetic abnormalities, there are some cytogenetic aberrations that have been included by ICC, but not by WHO and vice versa. And finally, AML not otherwise specified is by the WHO refers to as AML defined by differentiation. With regard to the diagnostic qualifiers, these are also included in the WHO classification. So this new ICC also impacts significantly on the initial genetic workup. And this is shown here on this slide. You can see that cytogenetics is still an integral part of the genetic workup, and results should be obtained preferably within 5 to 7 days, realizing that in many, if not most institutions, this is really a very challenging time window and is not really realistic, but we should set ourselves goals. So with regard to the screening for the gene mutations that are listed here, results for the actionable therapeutic targets like FLT3 or IDH1 and IDH2 inhibitors should be available within 3 to 5 days. And this also includes the NPM1 mutation status. Then the remaining list of genes, as you can see here, that has been extended mainly based on the list of genes belonging to the myelodysplasia related gene signature. And we also included DDX41, which may become a very important player. And these results should also be available within the first treatment cycle. And screening for gene rearrangements can be performed by PCR very easily or by FISH analysis if a rapid information is needed or if the morphology of the karyotypes of the chromosomes is bad. So additional genes are listed at the bottom of this slide, but this is a recommendation. This is not required for established diagnosis, and these genes cannot be used or the information of the gene mutation status can be used to monitor the disease by, for example, next generation sequencing based monitoring of measurable residual disease. However, this is still investigational, but it is important to provide such a list because this is a really rapidly evolving field. So as you know, there was also an update of the ELN classification, risk classification, and the major changes here are highlighted in red. So you can, based on recent studies, that have shown that in-frame mutations of CPB alpha affecting the basic leucine zipper domain of the gene, these mutations confer a favorable outcome in these studies, and this was irrespective of their occurrence as monoallelic or biallelic mutations. Then you can see that AML with FLT3 ITD is now categorized into the intermediate risk group, and the FLT3 ITD allelic ratio is no longer considered as well as the NPM1 co-mutation status. And then there is a refined definition of complex karyotype. I will come back to this in a minute. And the mutations defining the myelodysplasia-related gene signature are now categorized into this adverse risk group. And these mutations that typically occur or are associated with secondary AML, they are also prevalent in de novo AML patients, in about 1/3 of these patients, and they are associated with an adverse risk. So with my next slide, I would like to briefly make some notes with regard to CPB alpha and with regard to FLT3 ITD. So this is data from a study performed by the German SAL study group, and they have analyzed 4,708 adult AML patients to reassess the prognostic impact of single mutant of monoallelic CPB alpha mutations. And as you can see, CPB alpha mutations were identified in 240 patients. 109 patients had a single mutation and 131 patients had biallelic mutations. And these single mutations were further categorized in mutations affecting the amino terminal transactivation domain, the so-called TAT mutations, and or the carboxy terminal DNA binding or basic leucine zipper domain, the so-called BCIP mutations. So overall, 157 patients had an in-frame mutation in the BCIP domain, either as a single mutation or as a biallelic mutation, and 83 patients had other CPB alpha mutations. And interestingly, patients with these biallelic CPB alpha mutations and patients with single mutations in the BCIP domain, they shared several clinical features. For example, they were significantly younger and they had a very similar co-mutation pattern with, for example, a lack of NPM1 co-mutations, but a high association with GATA2 mutations. So this is the most important finding from this study. Survival analysis showed that the favorable outcome was confined to the group of patients with BCYP in frame mutations indicated here by the green curve. And this was irrespective of the occurrence as a mono or a B-allelic mutation. And the same data or the data could be confirmed by multivariate analysis. And very similar data have been reported by other groups, including our group. We have presented data on almost 500 CPB alpha mutated AML patients at the last EHA meeting. So as mentioned before, AML with FLT3-ITD are now categorized as intermediate risk, irrespective of the ITD allelic ratio and irrespective of the NPM1 co-mutation status. And there are several reasons why this has been changed. So first, methodological issues, because it is very difficult to standardize the FLT3-ITD allelic ratio between the different labs. And then there is an increasing role of the importance of measurable residual disease for mutant NPM1. And also the ELN clearly notes that the initial risk categorization may change during the treatment course based on the results of the NPM1 MRD status. That means if a patient achieves MRD negativity or not. And then finally, there is an impact of midostaurin-based therapy on these FLT3 ITD positive patients. And what is also shown on this slide is data from the large RATIFY trial where we looked at the impact of midostaurin in the different NPM1 FLT3 ITD genotypes based on the 2017 ELN risk categorization. And as you can see, there was a consistent beneficial effect of midostaurin on overall survival across all three different risk categories, including a significant benefit in the adverse risk group. So ELN also refined the definition of AML with complex karyotype, and this is data from a recent study published by Eli Papa-Emmanuel on a combined genetic data set from our group and the UK and CRI. And you can see here on the left-hand side, this shows you a hierarchical schema of AML class assignment. And there was one class that is shown here on the left-hand side that was designated trisomies, and which is defined by 3 or more trisomies without class-defining abnormalities and without any structural abnormalities. And as you know, in the previous definition, such cases were classified as complex karyotypes. So on the right, you can see the Kaplan-Meier plot that illustrates overall survival of this trisomy group in the light gray color. And you can see that these cases have an intermediate risk outcome, whereas AML with complex karyotype indicated by the red curve is excluding these trisomy cases has a very poor outcome. So complex karyotype is now defined by more than 3 unrelated chromosome abnormalities in the absence of other class-defining recurrent genetic abnormalities. And it excludes these trisomy cases, means with 3 or more trisomies without structural abnormalities. And I think this is really a relevant refinement of the definition of complex karyotype. It further sharpens the poor prognostic profile of AML with complex karyotypes. So with my last slide, I would like to summarize. There have been major advances in our understanding of AML, including the new knowledge about the genomic landscape, which leads to an update of the disease classification, a refined risk classification, and the identification of predictive factors. And there are also, there's also technological progress in genomic diagnostics and the assessment of measurable residual disease. And these recent advances are reflected in the new international consensus classification of AML, as well as in the updated 2022 ELN recommendations that include a revised ELN risk categorization, revised response criteria, and updated treatment recommendations. With my last slide, I would like to thank all our collaborators, and I would like to thank you for your attention, and I'm happy to take questions. Thank you.
Thank you, Dr. Döhner. Some question?
Maybe we can take this question from Dr. Allen from Newcastle. Hello, Jim. Nice to hear from you. So he says, very nice talk, and ask whether, can you comment on whether TP53 mutant clone size affects outcome? And presumably cases with a high frequency TP53 mutant clone have worse outcome than those with a low frequency mutant clone.
Yeah, this was exactly one of the questions that has been addressed in the study performed by Peter Falk's group in the study published in Blood. They had no cutoff for TP53 VAF to include patients with a TP53 mutation in their cohort, and they evaluated different VAF thresholds starting from 5% over 10% up to 40% and higher, and there was no difference in outcome with regard to these different VAF thresholds in their study.
Excellent, thank you very much.
I've got a question. I was given the great job to reallocate all of our patients according to ELN22, which I'm halfway through. NUP98 NSD1 and other NUP98 fusions, am I right they should be considered intermediate risk in ELN 2022? And do you agree with that?
Which patients, Richard?
NUP98 NSD1 fusion.
I think they are included in the, I have to go back and have to check, but I think so, yeah.
Because before they would have been high risk because of the high allelic ratio they nearly always have, and they seem to do quite badly. So would you agree with them being intermediate risk?
I do agree.
Okay.
Yeah.
Do you think that this new classification could impact on the choice of the CPX351, because it's difficult to diagnose by 3-5 days all MR related changes, especially mutations? So when you decide to use CPX, do you use this classification, or do you use the WHO 2008 that was the classification that the pivotal study of CPX used really?
Yeah, I mean, there was a lot of discussion because the AML MRC was eliminated by the ICC. But at least, I mean, when you look at the definition for AML MRC, you can pick exactly these defined variables, like, for example, you can pick therapy-related AML, you can pick, this is in the approval of the drug, you can also pick the complex karyotypes or the myelodysplasia-related cytogenetic abnormalities. And I think for the definition, you can pick the different variables from the ICC, and you can treat your patients with CPX, with the CPX treatment. And there was a very interesting study, I think presented by Nigel Russell. Probably you know these data. He presented them at the EHA meeting, and he compared within the AML19 trial from your study group, FLAG-IDA versus CPX. There was not a really difference for a response, overall survival, and relapse, but there was, I think, for the remission duration and for the relapse-free survival, there was a slight benefit for the CPX group. And then there was a presentation at the ASH meeting, help with the name, Ottman, and he found out very briefly that in particular the patients with the myelodysplasia related gene signatures seem to benefit from this treatment. So I think we get more and more data and we need to go, I think we have to leave a little bit this AML MRC definition and maybe go more into the genetically defined subgroups and look who is benefiting from such a therapy. And we have a running trial, a large trial with 800 patients with intermediate risk and adverse cytogenetics, randomized versus conventional therapy and CPX. So we will get some more interesting information when the trial is closed and we can do the analysis.
There is another question, I think, coming from Armenia, from Dr. Yara Manyan. Hello, would you like to?
Everyone, can you hear me?
Yes.
Sorry that I'm not participating in person. Thank you for very good presentation, Professor Döhner. And my question is about two classifications of myeloid neoplasm, ICC 2022 and WHO 2022. As you mentioned, there are some differences and also some similarities between these two. But like major differences are like MDS AML category in ICC, and WHO retains MDS IB2. Like how do you handle these differences? For example, if you have patient who has like 7% blast and also, for example, NPM1 mutation, and your pathologist gives diagnosis, for example, MDS, and you send this sample to another lab, for example, to MD Anderson, and they make diagnosis with WHO 2022, and they give diagnosis AML because, for example, WHO 2022 does not set any threshold for blast percentage if you have AML defining mutations. So I want to know your opinion. How do you handle these problems coming from existing effective two classifications? Thank you.
I think this is a question that has been discussed a lot within the hematology community over the last months when these two different classifications came out. And I think this is really not a good situation, to be honest, that we have two different classifications now and that there is a fraction for the one and a group for the others. And also for the pathologists, this is really very, very difficult. So never send a sample to the MD Anderson, so you will not get in trouble. No, but I mean, this is something, I mean, there is a clear, with regard to the blast, just taking this as an example, there is a clear difference between the two categorizations. And I think we also have evidence based on the data from Eli SD that there is, with regard to outcome of these patients, it is not really a difference. And we also know from the biological insights that we have got over the last years that it is a continuum. So do we have a gray zone between 10 and 19%? And the only, or one positive effect to what I would like to see or what I'm in favor of is that we are now able to include our high-risk MDS patients also in clinical trials for AML and vice versa. So this allows these patients to get access to novel trials, to novel drugs, to novel therapeutic agents. And I think we always have to make the decision which classification we are using with regard to many, many aspects of the patient. And it's not only the blast threshold, it's much more, it's a genetic profile, it's the patient itself, and the possibilities that we can offer to him. So I'm in favor of the ICC, to be honest, because it is an update that reflects the developments in the field as well. That is true for the biological and genetic developments that have been made, but also this has also consequences with regard to treatment. But we have lots of discussion, and we still will have lots of discussion what we should do with the new two classifications.
Thank you very much.
You're welcome. I think we have to move on. Huh?
So, thank you.